So when we talk about polycystic kidney disease in children, usually it's referred to as autosomal recessive polycystic kidney disease, which is a condition that occurs mainly in children. It can be diagnosed as early as prenatally. During fetal ultrasound, you can detect enlarged hyperechoic kidneys, which is a bright kidney on kidney ultrasound. In autosomal dominant polycystic kidney disease, which is referred as the adult onset polycystic kidney disease, it can occur in children, usually asymptomatic, unless it's a very early onset disease. It's inherited in an autosomal pattern, which means one of the parents has to be affected with this condition. It's usually asymptomatic in children, but if it presented in children, they can develop hypertension, complication of kidney cyst, including flank pain, blood in the urine, urinary tract infection.
So both of my daughters complained a lot about headaches, a lot of abdominal pains, back pains. The physical therapist actually on manual manipulation of her back felt something in her lower back and said, I really feel like you should be asking for an MRI or something. Something doesn't feel quite right. And then from that diagnosis, when she saw the pediatric nephrologist and he learned that she had a sister 13 months younger from the same father, asked if she would want to be seen and evaluated as well.
Patient can be diagnosed incidentally when they have abdominal imaging studies for a different reason, including abdominal pain and specific trauma evaluation for abdominal pain and appendicitis. Other methods of diagnosis include symptoms related to ADPKD, including hypertension and blood in the urine, flank pain, especially if there is a family history of ADPKD. Sometimes family screening, the parents request their child to be screened for ADPKD, and this is how the diagnosis is made.
Parents who know that they have the disease and they have conversations about whether or not their children should be tested. I would say that it's a very personal decision and a decision that I think that children and parents should make together and have those conversations together along with any input from their physician or any science-based research.
If there's a family history of ADPKD, usually parents can request from the pediatric nephrologist to screen their children for ADPKD. That should be a shared decision-making to screen kids at risk. Usually a kidney ultrasound is recommended, and with a positive family history, if you have at least one cyst in the kidney for kids who are less than 15 years of age, the diagnosis of ADPKD is likely. Children diagnosed with ADPKD, they need to be monitored closely for hypertension. If there's hypertension in pediatric ADPKD, the risk of prognosis is rapid compared to children who does not develop hypertension during childhood. Also, the presence of protein in the urine could be a risk factor of progression of the disease. Usually we recommend maintaining healthy weight, adhering to healthy diet, lifestyle modification, and high fluid intake, mainly water. If the child has high blood pressure, we offer blood pressure medications. Also, these blood pressure medications, some of the families can target the high protein in the urine with patient with ADPKD. We try to assure children that although this disease occurred during childhood, diagnosed in childhood, the majority of complications usually happen during adult period.
I'm trying to raise my children, who now have been diagnosed for about 10 years, with a healthy respect for PKD, but at the same time, letting it live alongside them like the color of their eyes, accepting it. Learn what it's going to take to prolong the progression of their disease and things that they can do every day, but also how they can cultivate joy in everyday activities. Every week, every month, every year, they're going to be living with PKD, and there are things that they can and need to do. And at the same time, there are things that I want them to not avoid doing and to embrace every day.